Hello, everyone. We'll get started in just a moment. Thank you for joining. We're just going to give everyone a chance to get logged on. All right, looks like everyone's getting successfully logged on. Justine, let's go ahead and advance to the next slide. So hello, everyone, and thank you for joining us for tonight's webinar as we discuss understanding wearables, heart data, and the OCORO Heart Study. My name is Nikki Butler, and I'm the Director of Digital and Social Media for the Dilated Cardiomyopathy Foundation and the Genetic Cardiomyopathy Awareness Consortium. We're so glad you can be with us as we discuss this important opportunity. We have over 430 registrants for tonight's discussion. Before we begin, I have just a few quick housekeeping notes. All attendee microphones are muted so that everyone can clearly hear our presenters. We will have a dedicated question and answer session following tonight's presentation. Please feel free to submit your questions at any time using the Q&A feature in Zoom. Please note that our presenters cannot provide individual medical advice. If you have questions about your own care, we encourage you to speak with your physician. Many individuals with genetic cardiomyopathy benefit from seeing a heart failure specialist at an academic medical center. We also ask that questions remain focused on the topic of tonight's presentation so we can make the best use of our time together. We do have a poll for tonight, so Justine, if you can advance to the next slide, and then we'll push that poll forward. We'd love to know who's attending tonight's webinar. Are you best described as a cardiomyopathy patient, a family member or friend, a medical professional, or an industry professional? Appreciate you taking the time to answer our poll. It is helpful for us to know who's attending. Give you just a bit more time to get your answers in there. It's always interesting to see the breakdown. It looks like we have about 37% cardiomyopathy patients, 16% family members and friends, 22% medical professionals, and 24% industry professionals. All right. I do want you to know that this webinar is being recorded and it will be posted on our YouTube channel following tonight's discussion. As registrants, you will receive an email with a link to the recording. Our YouTube channel also houses a library of our previous webinar recordings. And using the auto translate feature, these videos are available in 54 different languages. Next slide. I'll begin with just a brief history. The DCM Foundation launched the Genetic Cardiomyopathy Awareness Consortium, or GCAC, in 2023 after recognizing a major gap in awareness around genetics and cardiomyopathy. We also realized these conditions couldn't be approached in silos. Many genetic mutations overlap across cardiomyopathy diagnoses, making collaboration essential. GCAC was created to bring patient organizations together to increase education, awareness, and support across all forms of genetic cardiomyopathy. The next slide. In just a few years, GCAC has grown from 8 participating organizations to 11 patient advocacy groups working together alongside the DCM Foundation. That growth reflects the increasing need for education and awareness around genetic cardiomyopathy and the power of collaboration in addressing it. We are incredibly grateful to each organization represented here for being part of this effort. And next slide. Before we get to our main presentation, we're honored to welcome several patient advocates tonight. Hannah and Bethany Keim are passionate patient advocates and co-founders of Heart Charged. They bring a powerful personal perspective to the conversation, using their experience to help raise awareness and support for individuals and families impacted by inherited heart conditions. And following Hannah and Bethany is Walker Fromm, CEO of the SADS Foundation. Walker is a dedicated advocate for education, research, and family support surrounding inherited cardiac conditions and heart rhythm disorders, helping connect patients and families with life-saving resources and information. So I will welcome Hannah now and turn it over to her.
Hi, I'm Hannah with Heart Charge, and I am so glad to be included on the webinar today. Heart Charge is a patient education, empowerment, and support organization began by two young women, myself and my sister Bethany. We were unexpectedly diagnosed with hypertrophic cardiomyopathy in our teens. And from our own experience, we know how important it is to build routine around what is sometimes an unruly heart condition. I have personally found that participating in this heart study that you'll learn more about tonight keeps you accountable and builds that routine for you. I know how important information is as a heart patient. My heart loves to behave in the middle of the day at doctor's appointments, but loves to go crazy randomly in the middle of the night. By participating in this study, information is being gathered to help healthcare professionals understand the picture beyond the exam room. And as a bonus, your cardiologist will have more information to go off from the reports to help you personally. And the best part that we like, especially in this economy, is that you get these wearables and monitoring devices at no cost to you. We have a fun video that will be shown later in the webinar that shows you an overview of what's included and what you need to do in the OCORO Heart Study. We hope you enjoy it and that you will join us at Heart Charge and enjoy other real, raw, and rather entertaining posts on living with a heart disease. And now I'll hand it over to our frequent collaborator and friend, Walker.
Thank you so much, Hannah. I'm Walker from the SADS Foundation, or the Sudden Arrhythmia Death Syndrome Foundation. For those of you who don't know me, I come to this space as a result of a few years ago, I had a daughter who passed away from an undiagnosed cardiac condition when she was just a small baby. And so this cause is very personal to me. Um, to be working with the SADS Foundation to advance research and knowledge to prevent tragedies like that from happening. At the SADS Foundation, we support families and save lives. We work to forward our vision of life unlimited by inherited arrhythmias, including channelopathies as well as cardiomyopathies that are genetic and can lead to life-threatening arrhythmias. We've been around for 35 years. Uh, we are primary patient home for folks living with long QT, CPVT, Brugada, and arrhythmogenic cardiomyopathies. We have a number of programs. We're really excited today to be part of co-hosting this presentation on the OCORO study through with sponsorship from Proleo. Like Hannah was just saying, it's so important for us to gather data. It's exciting how Proleo has designed this study to take advantage of the latest technology so that you can participate from home. And the vision of trying to shift the conversation in cardiology from being very reactive, right? We didn't know, in my personal experience, right? Like we didn't have any warning signs. It was all reacting to what happened with my daughter. I love the vision of a world where we, by joining in to research like this, can help move the field to be proactive, where we can predict ahead of time when things could go wrong, how to prevent them. So we're really excited to be part of this and grateful for our collaboration with Heart Charged and the DCM Foundation and the broader Genetic Cardiomyopathy Awareness Consortium project. So thank you, Nikki. I'll turn it back to you.
Thank you, Walker. Our featured presenter tonight is Greg Kurio, cardiologist and principal investigator of the OCORO Heart Study. Dr. Kurio will share insights into the study, its goals, and how this important research aims to improve understanding and care for individuals at risk for inherited heart rhythm conditions. Greg?
Thanks very much, Nikki. Thanks for the preamble, Walker and Hannah. It's really a pleasure to be here, and we can go ahead and start with the slides. You don't need to look at my picture any longer than you have to. We can go next slide. These are my disclosures. I'm an employee of Proleo, hence I am the principal investigator, and I am a consultant to a biopharma cardiovascular company called Cardigan, which is our parent company. Next slide. So going over a little of the scope that we'll be talking about today, a little history of wearable technologies. I think that we are living in a time where it's really exciting to see everything that's coming out in wearables. I'll touch on some details that maybe get glossed over in the media and in advertising for selling wearables, et cetera. I do see a lot of promise and differences in the wearable technology data. It's allowing us to see data at a cadence we've never seen it before, and with a precision we've never been able to see before. And I'll go over a few of the FDA regulatory pathways. Sorry if that doesn't sound super interesting. I think these are details that are very important to understanding what you're getting when you're putting a wearable on, et cetera. And as with any new technology, we've got challenges. It's a blessing and a curse, like with everything that comes along to help us take care of patients. Not in the scope of the presentation are really the how of this. I'm not going to go into how different wearable sensors calculate your heart rate or your AFib or things like that differently. And I also don't want to go into the methods of analysis and algorithm development, with apologies to any of our data scientists and statisticians in the audience. I do want to take the time to thank everyone who is watching now. And if you're watching this weeks or months down the line, thank you for signing up and listening after the fact. I loved getting to know this community of people that y'all have built between DCM Foundation, GCAC, and the advocacy groups, Heart Charged. Been great getting to know Hannah, Bethany, and your mom, as well as Walker and the SADS Foundation. So I want to also thank my scientists at Proleo, without whom this would not be possible. So next slide. So jumping right into it, sort of comical. I am not going to make y'all wear that thing, which apparently weighed about 70 to 80 pounds. Norman J. Holter. So all of you who are patients and have worn a Holter monitor probably didn't know it was named after that guy. And the original portable ECG was that thing that guy on the bike has strapped to his back. It was the first to say, well, we can get ECG data without you being in clinic. We can get it multiple hours as long as you're willing to carry 80 pounds on your back. And this was a shot across the bow, the humble beginnings in 1947 of where we are today in wearable technology. It paved the way for modern ambulatory monitoring. So next slide. And this is where we are today. And this doesn't even include the rings. And I saw something about a smart earring the other day, which probably doesn't look that good on me, but who knows what's next. Since Norman Holter's, I think they used to call him Jeff. So his innovation in 1947, it took until 1982 for Polar to introduce that chest strap that many of you have seen. So that's been around since 82. And then another 30 years before PPG, or photoplethysmography. I'm going to have to abbreviate that PPG because it's hard for me to say. But that's really where that technology with the light sensor in your watch or your ring achieved significant miniaturization and able to be run by small batteries, where Apple said, hey, I'm going to jump into watches. So the Apple Watch was introduced in 2015. But it wasn't very long before Apple then said, hey, I wonder how many people would enroll in a study with our Apple Watch. So in 2019, they enrolled the Apple Heart Study, the original one, and that enrolled 419,000 people in that year. And then in 2021, a company called Fitbit, which has then been absorbed by Google, said, well, we can probably do better than Apple. And they enrolled 455,000 participants. So this is where we are. There's data everywhere, and there is the potential to see things that are outside of the clinic, outside of what we as practitioners have not been able to see. So next slide. So this is funny, but not funny. From a practitioner perspective, this is how we see the blessing and the curse of wearables and the advent of always-on data collection. Patients are buying wearables and they're cool to wear. They tell you lots of things. They give you your email and your texts on the device in some cases, but they also give you warnings. There are algorithms that are out there that take your data and with the best intentions give you warnings. And this is kind of funny, but it is the reality. People are always coming to our clinics and saying, hey, my Apple Watch said I have AFib. Do I have AFib? You've never told me I have AFib before. Is it really bad? Am I going to die? Am I going to have a stroke? These are things that I think raise the temperature of the clinic visit, and in many cases, not really knowing what the repercussions are going to be. AFib, which is a really common metric to measure, it's really specifically a tough nut to crack. And I think it's prevalent. There's something you can do about it. A lot of people have it, but we all have extra beats throughout our daily lives. And the differentiating those extra beats from AFib can be pretty difficult for a computer or an algorithm. So there are a lot of false positives here, which can, raise your anxiety level. It's important to know for these extra beats in the AFib what makes them concerning to a cardiologist. For extra beats, so you may have heard of things like premature ventricular complexes or premature atrial complexes or PVCs and PACs. For me, as a pediatric cardiologist, they're super common. A lot of kids have them. They're far and away very benign. If they just happen one at a time, they seem to be coming from the same part of the heart. And if the child or the adult raises their heart rate, they should go away. If that doesn't happen, I get a little bit more concerned, but that by no means means that you're going to have a stroke or a terrible event. Dense data, in the way that we collect it with the wearables, answers a lot of these questions. It comes at a price. It comes at a price of anxiety. It comes at a price of visiting your doctor when you didn't really want to come and see us. That raises your anxiety too, I've been told. So this is the needle that we need to thread with wearable data. So next slide. So what's the promise of continuous data? Why does it help me and the rest of the people who do cardiology care take care of our patients? If you look at the continuous heart rate that we see here, the red dots, you might think, if this is your heart rate, that over the course of the x-axis, which is time, your heart rate's going up. That could tell me something. But then again, if you click again, Justine, look at the black dots. If you looked at this, you would say, oh, that person's heart rate is definitely coming down. So these are spot checks that we have traditionally been able to look at in clinic, or even getting you to, call in and say, hey, this is my heart rate right now. Imagine a world where the ECG is sampled at 125 times a second. That's 180,000 data points in a day. Add to that the fact that I can track your movement of your wrist or your wherever you're wearing your device. Accelerometry, or the ability to track your movement in space, can be sampled at about 25, 30 hertz. That's about 36,000 samples per second in 3 directions. You got this direction, that direction, and this direction. So that's a lot of data to go through. And you probably know where the punchline is if you click again, Justine. The punchline is this is all one person's data. So depending on when I sampled it, I could have very, very different impressions of what's going on with this person's heart rate. But the continuous data helps me figure that out. And click again, Justine, please. So what's the true trend? What do I react to as a cardiologist? I don't want to look at, what is that, 180,000 plus 36 times 3. So somewhere on the order of 300,000 data points. I don't want to sort through that to tell you how you're doing. And click again, Justine. Because this is what I would look like, sorting through all of that data for every one of my patients that needs it on a daily basis. So we need to be very responsible about how we send the data to practitioners and how we parse the data as practitioners. Next slide. So what is the impact of continuous data? And how do I decide how much data I need as a practitioner? If you look at the previous example, and if you look at the graphs on the right, how much data is enough? If it's heart rate, I do want everything. I want it all because some of it will be very, very noisy, depending on whether you're wearing a ring or a watch or you have it stuck to your chest. There will be times when you're exercising and there's so much noise, I can't really tell what the heart rate is at that moment in time. But when things quiet down and you're still, that data will be much more available to me. So therefore, I want all of this data. We need to be able to say, great, I can take away data that doesn't meet my cleanliness metric and say, well, that's too noisy for me to interpret. But a few minutes later, totally interpretable. So the more the better. If you think about things like blood pressure, go back to the last time you saw the doctor. How many times did we take your blood pressure in the clinic? If we were doing a good job of it, at least once, twice if it was high. So it's very different between ECG and blood pressure. Blood pressure, gosh, if I had 3 readings, 5 readings throughout the day, that's already way more data than I had before. So I could probably make a really good assumption about what your blood pressure does throughout the day if you gave me 3 or 5 readings. Heart rate, on the other hand, as we saw from the previous slide, slightly different. So we've got to be thoughtful about how we want the data presented to us. Next slide. So that brings us to, what is the data that is coming through to us? What does FDA cleared mean? You're going to hear that a lot in advertisements. You're going to hear that from even talking to me about the study. So what does it mean? And I think this bears some clarification. That first line there that says type of use, and there's a check mark under prescription use, and there's an empty box on over-the-counter use. This actually is pulled directly from the letter that the FDA sends to us, which is a response to, hey, you submitted this device, or in our case, software, as a medical device. So we submit a computer program that we claim it does something and measures something that the FDA then looks at our data and says, yeah, it does. Or maybe they say, not convinced, go back and try it again. But this is very important. If it's prescription use and that's checked, a doctor has to give an order, and then the data has to come back to a licensed practitioner for interpretation. You cannot use it and you cannot acquire it as a private citizen who's not licensed. Over-the-counter use, on the other hand, you can basically say, that's what I think it's measuring. And there is a lower bar there, and that would be something that you could buy at Best Buy or something like that. You can go through the criteria for medical grade versus over-the-counter. We talk about the risk to the user if the data is either erroneous or misinterpreted. And that is really the bar that the FDA sets for itself. Is there a potential for harm if the reading is wrong, or by how much can it be wrong? Or is there potential for harm if somebody misinterprets the data, either is falsely reassured or falsely alarmed by the data? That is the bar for medical grade devices. If it doesn't really matter, then it can be for entertainment purposes only, so to speak, and over-the-counter use is perfectly fine. That would be stuff like Band-Aids. And now that the glucose monitoring is something that you do yourself, you can actually even have continuous over-the-counter. Those things, FDA has said the risk to the patient is pretty low if it is either misinterpreted or misused. Smart devices, most of the things you see will come under this heading. For us, ECG patches, machine learning platforms, AFib burden, where a mistake in interpreting the data could be deleterious to the patient. However, I think we really need awareness of this, because when you see it in the media, they're all considered FDA cleared, but it can mean very different things. So next slide, please. So the state of FDA clearance, and granted, this is a couple of years since I put this together. So the digital health medical grade, we lag behind the radiologists. The radiologists clear a ton of things because they go through so many X-rays, CTs, MRIs, ultrasounds, that they really need a way to parse the alarming from the not alarming, even if it gives them a time edge and something that's very abnormal comes floating to the top of their queue, that's super helpful. So if you look at the AI-enabled technologies and the medical grade technologies, the radiologists kind of have us all beat. I think people are very curious about what Apple has and what Verily has, and they have a very different approach. Apple had 5 at the time of writing this slide, which was about 2+ years ago. I looked this morning, they are up to 9 510(k) clearances. 3 are updates to prior things that they had cleared. So this is basically just new functionality added. You do have to go through the same 510(k) process with the FDA. It's a little easier. Only 3 of the 9 are medical grade, and they would be ophthalmic prisms. In other words, like I don't know how many of you have played with or looked at the Vision Pro goggles, but if you need a prescription, those have to be corrected, and obviously those have to be under the auspices of an optometrist, et cetera. And then there is one radiologic grade calibration of their Apple monitor that is a medical device. Otherwise, all of their other clearances, including AFib or the hypertension. So AFib just measures how irregular your heart rhythm is, and the hypertension will give you a readout of you may have high blood pressure based on our algorithm. Those are all over-the-counter consumer-grade devices. Verily has taken a very different approach. They have all medical-grade clearances, and they cleared a device called the Study Watch, which is actually, as near as I can figure, I've never had my hands on one. It seems like the ECG functionality that an Apple Watch has. If you have an Apple Watch, you kind of touch the crown and that completes the circuit between your 2 arms, a little bit like putting the stickers on your shoulders for the ECG, and that gives you an ECG. They cleared it in 2017. They updated it in 2022. I think the adoption just has been really low, and that's why we've never heard of it. And since it's prescription only, you'll never see it in everyday life. So that's kind of the state of things right now with famous companies. Next slide. So this is one that I had created for a different wearables medical conference. So just to kind of go over some of the abbreviations that may not be super universal. SpO2 is pulse oximetry, so that's the oxygen content of your blood. Respiratory rate, RR, blood pressure, you guys all know. Heart rate variability is a measure of beat to beat. How much variation in milliseconds is there between your heartbeats? And some of you that are very into the sports tracking technology realize that this is an up and coming metric. But the device on the right is something called the Corsano, which is the medical grade device that we're using, and it is from Switzerland. But the point of the slide is to look at how close the capabilities of all of these devices are, and to reinforce that FDA clearance type, over the counter or medical grade aside, consumer grade devices, in other words, the things that you can buy at Best Buy, are definitely not inherently worse. They're not in that category because their technology is inferior or what they're measuring is not as exact. It's a business decision because you need to compel the collection of data that can prove to the FDA that this should be used in a medical situation. So if you're going to sell $15 billion worth of Apple Watches, it's probably not great use of your resources and time to get that clearance. So that's kind of where we're at with the clearances. But I just wanted to make sure of all the things that we talk about, having a distinction between FDA medical grade clearance and consumer grade clearance by no means that the technology is inferior. It's really scientifically sound development. It's just a business decision. And I neglected to mention on the previous slide, FDA clearance does not focus so much on the accuracy of the measure. When you submit to the FDA, you basically say, these are our acceptance criteria. If we're accurate within this range, please clear the device. And they can reject or accept your acceptance criteria. But generally speaking, they see their remit not as being super accurate, but being super safe. That misinterpretation thing is really what they focus on. Next slide. I wanted to go over a couple of things that are kind of hot right now, at least in my mind, in my world, in terms of wearables and the ability to measure clinically meaningful things. non-invasive cuffless blood pressure is one that has gotten a lot of press. I think for those of you not in the biopharma sector, high blood pressure has become sort of hot again. In other words, there are more new compounds, new ways to treat it that I think it's developed a great interest. And the ability to measure it at home more times throughout the day. Like I said, I don't want it continuously, but if I could have it 5 times a day, it's super helpful. So the ability to do it with a wrist-worn device or a ring or something like that is of extreme interest. And the ones that I have seen measure about every 2 hours. But the key part is they take every bit of data within that 2 hours that is of sufficient quality to make that estimate. And some of you who have hypertension or who have blood pressure issues may have worn ABPM or ambulatory blood pressure monitoring, which is basically a cuff attached to a thing that's attached to your body. I've never found it, it's the gold standard, don't get me wrong, but I've never found this to be very comfortable or super convenient to my life. And I always wonder when it wakes me up in the middle of the night. I know fragmented sleep is a risk factor for high blood pressure. Like, are you raising my blood pressure or are you just measuring it? So I think there's a desire to do this. I think you get better data and you eliminate the problems that you get when you have a cuff that's too small or too big. And I think there's a real need for this. Calibration's a problem. Sleep quality with ABPM is a problem. But that, I think everybody agrees that it would be a great technology. But if you go to the next slide, the opinions of the governing bodies for all of what we do, the European Society of Hypertension, the American Heart, American College of Cardiology, all recommend against the use of any kind of current cuffless technology in the diagnosis and management of hypertension. They cite lack of standardization for validation, difficulties in calibration, and inconsistent results across trials. I think there is a need to do it, but the big challenge is right now, everybody has come down on the side of don't do it because to the FDA and to these medical societies, all of this is, it's a diagnosis. You're basically telling somebody they have this disorder that needs to be treated. And I think that raises the bar for how good our data has to be. Next slide. Contrast that with atrial fibrillation. That has come such a long way since the early 2000s. Now that we have continuous data by patches, we've started looking at AFib burden for people who have implanted pacemakers or other devices. The body of data has been collected such that the same institutions and governing bodies are saying, well, yeah, you could use device-detected AFib to figure out how much AFib you have. That's I think it's quite a sea change that we're seeing in the last 20, 25 years is that, yeah, you could use a device and we would say that is AFib based on what the device says. Granted, harken back to what I said about AFib's a tough nut to crack, but I think this shows a willingness on the part of medical societies to get the data however they can, because we're dealing with stroke risk here. We have a lot of disagreement of how much AFib is significant. There is definitely a huge difference between if I have AFib, if I have it 1 minute out of every 3, how does that risk translate to somebody who wears a patch for 3 days and has AFib continuously for 24 hours? I would argue that the time you spend in AFib, the fact that you're in it for 24 hours increases your stroke risk, but it is a discussion that electrophysiologists far smarter than myself still argue quite vociferously. So we're at a crossroads where wearables can really make the difference. We need to collect the data that says they do make the difference. So the next slide. So what's the future vision of what we want to do with wearables at Proleo? And I think there are many, many like-minded people out there that don't work at our company. But I think the benefits to clinical care and to how we monitor and take care of our patients fall into really three things. Decentralization is a term that is given to breaking away a bit from the standard care paradigm or the clinical trial paradigm. Historically, you used to have to come to clinic, come to the hospital, and see your practitioner, and we would look at the data from that day, your echo, your ECG. Maybe I stuck a 80-pound Holter on you or something like that. And I'd look at the data and I'd say, here's what we're going to do. Come back in 3 months, 6 months, a year. And in clinical trials, it was really limiting for people who had to come to the Mecca where the trial was being conducted in order to get their blood pressure, their echo, et cetera, measured. Decentralization speaks to the inclusivity of trials. Can I meet the patient where they're at? Can I send it to your house so you can collect the data and it'll just come to me? We're at a really unique time in history when this is really possible through multiple devices. I think it would increase the representation in trials. I think it would give us better data that what we're trying to do translates across social determinants of health, ethnicities, races, that sort of thing, where we can get everybody into a database where we can get all of that insight. And I think this is where we have to move. It also, for us running trials, it has the added benefit of accelerating us to critical mass of data and decreasing the cost. If we don't have to bring you into clinic and pay for transportation and pay for expensive tests in clinic, that probably makes it a little bit less costly to run the trial. Certainly, sometimes testing does cost and does require a very, very specialized site, and we will make those decisions whether that data is really stuff we need for getting these insights. Device integration, going back to what I said about the consumer devices are not inherently bad, and they're certainly not worse. These are well-engineered devices. Is there a way that whatever you've got on your person, whatever your favorite device is, can I collect that data in order to gain insights to the population that has your particular disorder or kind of is in your stage of the cardiac journey? I think that's really exciting. And the density of the data gives us deeper understanding. The more data we have, the more we understand. It's not untrue when our colleagues that are developing AI approaches to ECG and stethoscopes, et cetera, it's not disingenuous when they say, we can see things that the average, even super well-trained cardiologist is not going to see because we can see so much data. That's going to be true. There are limitations of human observation and the human brain. There are advantages to the human brain, but that's kind of what we see next. So moving along to the OCORO study, I want to talk about that very briefly. So we stood up OCORO because we believe in all of those future states. Next slide. And what it looks like is it's a remote observational study. It is completely decentralized. We kind of drew a line in the sand, say, I'd love to have 5,000 patients monitoring for 5 years. I'm not going to hold anybody to the fire for 5 years, but we want to learn how to make a trial enrollable and sticky so that you want to stick to it. The population should be super wide. It should apply to anybody with any kind of cardiovascular disease. One of the things that has been troubling to me as a pediatric cardiologist is there is not a consistent measurement throughout your entire cardiac history. So if you move from one diagnosis to another, for instance, just to use something that I think is near and dear to this group, my patients move from hypertrophic cardiomyopathy to a form of dilated cardiomyopathy, at a far greater rate than the adults that have HCM. So I've never been able to track that. They move from one registry to another and the measurements aren't the same. I think there are the same things in adult cardiology where we look at things like aortic stenosis. So if your aortic valve's too narrow, it gets narrow to the point where you get a valve placed either surgically or with a catheter. You go into another registry. You still have high blood pressure. That's a different registry. High blood pressure then turns into some form of heart failure. That's another registry. So we really wanted to track somebody's entire cardiac journey. So that's really why it stood up this way. And what is it not? It's no new meds, no clinic visits. Your cardiologist is still your cardiologist. I just want to see how your cardiac journey goes through. It is importantly not a monitoring or alert system. If something is concerning, it is a bit like calling my office and you're going to get that message that says, if you think it's an emergency, dial 911. It is not used for alerting you to things that are going on. Having said that, I think there is great value in the data. Next slide. And I think that what we really want to do is make sure that we're all part of a community. I would love the patients and the participants to weigh in and say, this is really hard for me to do. Can we change it somehow? There is flexibility. There is feedback from the participants that say, this is hard to adhere to. Can you make it easier? And that goes back to developing the stickiness of studies that we want and that I think all researchers want, whether you're doing other registries or whether you're doing clinical trials in therapeutics like pharma. I think that give and take with the participant is going to be very key. So we have built that into the structure, both having participants' feedback as well as giving participants back their data in terms of how have I been doing, in much the same way as you want to get it from your wearable device. So next slide. These are the devices that are currently kind of the basic kit through the OCORO study: blood pressure, weight, ongoing questionnaires that you'll get through a lockdown smartphone. You won't be able to watch YouTube on it. It just handles our data and then gives you out questionnaires, etc. The ECG patches, they get a little bit itchy, so we don't want you to wear them too much. So generally speaking, the baseline is you wear it for a week every quarter. There will be certain cohorts of people where he said, can you find it in your heart to wear the patch a little bit more frequently because we want denser data there. The cardio bracelet that we talked about, and we do want the EHR connectivity, and that is a fancy way of saying, I do want to see your medical record. It is something that you would own, and we would do it through a method that the US government has set up called TEFCA, and using an individual access system where you say, I want my medical record data and I want to be able to do with it as I please. In other words, not just sending it to OCORO. If I want to participate in something else, that you are free to do. You're also free to say, I don't want you to have it anymore, please delete it. So that kind of control, and we'd love feedback on whether that is meaningful to participants. So that's the data collection. Next slide. And what would you expect? You wear the cardio bracelet all the time. You wear the patch 1 week out of every quarter, answer some questions when the questionnaires pop up on the app, and then connect the medical record via the individual access system that I mentioned. Next slide. And what would you expect in return? This is a heart health report. That's not unlike what you would get if you sign up for Fitbit, Apple Watch, etc. It is basically heart rate, blood pressure, weight, anything that you've measured, anything that you've had, you've answered on the phone, and it'll, like a lot of other apps, give you some information and educational material on the findings. So next slide. Who can join? Right now, this is limited to everybody 18 and older, which pains me as a pediatric cardiologist, but the field is wide open in terms of what disorders would we be interested in. Obviously, all of the cardiomyopathies, the genetic myopathies, all of that really needs somebody to build dense data and models and profiles around. Arrhythmic disorders, inherited or acquired. Valve dysfunction has huge implications on your cardiac physiology, and we think we can detect those early signs as well. Heart failure from any etiology and even high blood pressure, all of that would be fair game, and we would love to have participation from all of these cohorts. Obviously, because we stick a patch on you once a quarter, a bad adhesive allergy would kind of rule you out. Next slide. So the path to participation, like we said, it's pretty easy. It's just signing up on our website. I'll give you a QR code at the end of the presentation, confirming interest, signing an informed consent form. We have both client success representatives and research nurses that are available to answer these questions. And then you'd basically receive these the biosensors by mail and then wear them. If there are issues or some confusion, client success is standing by to sort those out. And I'm going to close with something I'm not going to give y'all with the OCORO study. Next slide. You will not be receiving this. Maybe one day. I actually don't know its full capabilities, but I've always thought, yeah, it's not exactly wearable, but it might be an interesting insight. So anyway, looking forward to the Q&A. Sorry, Greg, I go over every single time. Greg already knows this, but I'm going to proceed to the video that Hannah promised because I think that is a really cool way to end this. Thanks very much, everyone.
Thanks so much, Greg and team. Justin, if you could go back a couple slides with the QR codes, that would be great. If you are a patient on the left-hand side and are interested in learning more about the clinical trial, please just take a picture of the QR code. If you're a healthcare provider, might be interested in this for your patients, again, on the right-hand side, feel free to take a picture and get that. Greg, thanks so much for that. That was wonderful, really good. I've been in the study. It's really easy. And as a patient, a father of a potential patients, genetic cardiomyopathy, and then also as running a patient group and foundation, I'm really excited about what the OCORO study is doing, what Paleo is doing, and helping to make cardiology less reactive, more predictive in nature. And so I really think personally, as Walker and Hannah said, I think this is really, really important. We're going to go a little bit over, probably till 7:10 or so Eastern time to answer questions. If you have questions, please just enter them in the Q&A box at the bottom of the screen. Click on that. We have about 8 questions so far, and I'm just going to run through them as we receive them. Greg, Dennis has, as a pediatric cardiologist, where do you see continuous wearable monitoring fitting into the screening of young athletes, and dose high density data help with the false positive challenges that's made one-time ECG screening debatable in kids?
Wow, you really let off with a doozy there,
Yeah,
Greg.
that's
Thanks, Dennis. Yeah, so as many people who know me know, even though I've been working in adult cardiology for the last 7 years, I've always got the ulterior motive of how does this benefit my kids? And I think that is yet to be determined for a couple of reasons, Dennis. First, there are not many of these continuous ECG monitors. So when we separate ECG from PPG, it's the LED derived is the PPG, and the ECG is stuff that you have stuck to you. A lot of those ECG patches are not approved for children or not FDA cleared in children. So the widespread use has not been adopted yet. As pediatric cardiologists, we can do whatever we want. We don't have to adhere to that. But I think there's been a hesitancy to really make decisions based on that. But to your question, it would be very useful. And I come down to like long QT syndromes where your QT, it's scary for people to think that a high percentage of long QT, genetically at-risk long QT patients have a normal QT, or at least a QT less than 470. And it is what your QTC or QT does in response to certain stimuli, whether it's exercise, swimming, sleeping, all of those things, different genetic makeups give you different risk. That's, I think, where the continuous monitor, if you could wear it and I could see what your QT does in response to all of those things, I'd have a much better idea rather than just restricting people who have a QTC in the 460 range. More to come on this. I think it bears a lot of thought, but we've got to be very deliberate about it in much the same way as we've been deliberate about one-time ECG screening.
Great. Thank you. And a lot of these are, do I qualify, right? So we'll run through these. Like me, heart transplant patient, can they participate?
Yeah, heart transplant without a doubt. That changes how your heart reacts to stimuli, mostly because you don't have the innervation that your natural born heart had. And studying this and what the signals are in somebody with a heart transplanted heart, super valuable data.
Cool. Thank you. Again, more questions in this realm. Are people with a genetic variant that is linked to cardiomyopathy yet with no symptoms, are they eligible to participate?
These are super good questions,
Yeah.
guys. I would say, at the risk of getting myself in trouble with the study team, yeah, if you have a confirmed putative pathogenic, likely pathogenic, or even your family has a variant of unknown significance and you have multiple people in the family affected, that is data that is going to be, as Walker was alluding to, that's the predictive data that we're going to want. So yeah, I might get slapped when I get back to the office, but yeah, come on.
It'd be interesting to see when symptoms start developing. It'd be really valuable. Can someone with an idiopathic SCA qualify to participate?
So if I understand the question correctly, this is somebody with an aborted sudden death event.
That's what I'm assuming, yes.
Yep. So I would say yes. We're finding so many things out from the genetics and what really drives arrhythmia syndromes, to say nothing of the fatal arrhythmia syndromes, that I would say if you've had the event or somebody has had the event, we definitely would want that data included.
Great. Francis asked, can patients have a pacemaker implanted?
Pacemaker implantation, at face value, yes. These patches are worn by people with pacemakers all the time. So I would be very interested to look at pacemaker data. I would actually be very, very interested to look at your pacemaker downloads in conjunction with the patch data. There may be a future state where there's been a lot of interest in bioimpedance and those scales that measure your fat, water, muscle content. My understanding is those, while my EP colleague says probably fine, we don't want people with pacemakers passing even little bits of current through their body. So you could probably, if that becomes a reality, I would just have the pacemaker patients opt out of it, but I would love pacemaker patients in here.
Can wearables interfere with implanted cardiac devices?
Oh, another really good question. So in my practice, as well as what we've been conducting from a research perspective, since it's a passive measurement of the electrical signal, they do not, at least the ones we're using. I'm not familiar with everything on the horizon. Anything that passes a current through your body, I'd be a little bit wary of, in terms of the wearables, but the patches have been fine, and the usual things like Apple Watches and Galaxy Watches have been fine.
And I know I did a lot pre-transplant, with patches with my CRTDs, so makes sense. Our friend Christy, does the OCORO study patient report include data tracking PVCs, PACs, and ventricular arrhythmias at all rates?
At all rates. And that's a real buzzword for pediatric cardiologists because a lot of people who write these algorithms don't realize how fast our patients can go. But that is the plan. It's not implemented in V1 of that patient summary report, but I am working on getting something that is meaningful, but yet not, what's the best way to say it? Let's back up. The one thing I want to avoid is to be the study or the person that tells you you have an arrhythmia syndrome before your actual cardiologist does. So we're working on a workflow that gets you that exactly the data you're asking about, Christy, but in a way that can kind of keep your cardiologist in the loop. Like they should know all of this as we know it. It won't be, like I said, it's not an alarm or a monitor that says you had VT at 200, which would be bad. But if there are concerning levels of PVC burden, VT, AFib with rapid ventricular response, there needs to be a way for your cardiologist to be completely looped in. So until that we're working on making sure that happens. But I think to your point, you'll want to know your PVC burden, so we should provide that.
Great. From Joseph, great presentation. Have you considered collaborating with pediatric heart failure providers like Action?
I know a lot of people who set up Action, and that would be really a dream. We've got to get, in my own personal opinion, we've got to get a critical mass of our influential pediatric cardiologists to say, we want to do this, and that will drive either exceptions to using the devices in an age group that they're not cleared for, or at least running a study that says this is key. As a pediatric cardiologist, I'm super interested in single ventricle physiology, all of those things that I think would really benefit from this. But I can't commit to anything right now. But yeah, that would be great.
Great, thanks. Little double question here. Good question. They're all good questions. And we have 23 questions so far, which is great. Again, we'll go probably to 7:10. We'd love to answer everybody's questions if we could. Could you see it can you use it if you already have a loop recorder implanted? Also, can the steps, etc., connect to other apps like Apple Health or Noom?
So first one, loop recorder, that'd be completely fine. Second thing, we don't have any way to connect to health apps like, I guess, the new Google Health or to Apple Health yet. As you may have heard, it takes a lot of contracting and negotiating to get what we need is the raw signal and the raw data from the device. And that's kind of been the holdup. There's a lot of proprietary protected stuff with Apple and Samsung that have to be sorted through. I won't lose hope. I have a dream that somebody will figure out that this data will raise all ships and we'll have better access to it.
Great. Again, great. Can you provide a lower arm BP cuff? Upper cuff is extremely painful and don't use in doctor's office.
We don't have that implemented now, and if we can get non-invasive blood pressure across the line, that'll kind of take all of that out of the picture. We don't have one integrated now. I won't say we won't, because that's not the first time I've heard that. And people with shunts and things like that, that'll be very, 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 very different. It'll also throw your blood pressure way off. So not as of yet, but I wouldn't rule it out.
Any future plans to expand OCORO Heart Study beyond the USA?
I would love that. So this was really set out this way just because it was the lowest hanging fruit. I have had some feelers from other countries, so I would love that to happen. It will take time because regulatory bodies and clearing research in other countries is always an order of magnitude more difficult than we thought, but that would be on my horizon personally.
Great. And this is a question. Will you provide, and this is for me, will you provide contact information via email rather than QR code? Yes. Nikki will send links in an email to you with the recording, most likely tomorrow or the next day. and she will have the links in that that you can just click on. Again, I think the answer to these are yes, but real quick. Jesse says, "Can I have this with a biventricular ICD implant?"
Yeah, so biventricular pacing with ICD, yeah, you can definitely use that. And we would love that data. I can't think of any situation where I wouldn't want the data, and I don't think it's going to interfere with your device any more than it would have with standard pacemakers or standard ICDs.
Yep. Another question about ICD pacemaker interference. I think we've answered that, which is great. Dennis said, "Thank you. Sorry for giving you a big doozy question." That is fine. We like big questions. This is hard. From Katie, what does the future look like for any type of wearable monitor to alert patients and caregivers in real time to heart irregularities, for instance, Brugada syndrome, so that intervention could take place in the event of cardiac arrest, for example, while a child's sleeping?
Yeah, this is a really tough one. So this is also a doozy. So there is always a lag with the wearable device. The minimal lag with the devices we're using is probably on the order of a couple of minutes. Even the best ones with a good signal, have a lag of at least several seconds, which would be tolerable. The problem is if you have a dicey Wi-Fi connection or a dicey cellular connection, you could conceivably have lags of much longer than that before the data caught up. So from an FDA standpoint, something like this would be what they call a class 3 device, where the failure of the device would result in a catastrophic situation. The bar is extremely high to be a class 3 device. So while I feel you, I agree this would if it helps one person, child or not, then it was worth it. But the FDA is always looking at what's the potential for harm. So clearing a device like that would be very, very difficult and require a lot of testing. So the honest truth is I think we're quite far away from something like that.
No, that's great. So this is an interesting one. In the ones, if you have ICD pacemaker, the answer is yes, you can participate. Will my cardiologist EPPCP be able to access my data, and will I be able to see my data and how? Two great questions. You went over briefly, but I think this is a great question to answer. So
Yeah, so we rolled this out with the information, that 30-day informational sheet, as a PDF that can be securely emailed. The vision, which is not far away because we're doing this to support some of our industry partners, is to have a dashboard, I guess, is the best way to think about this, so that you could access previous data, current data, etc. With the app on the phone, you can see your ECG in real time if you're wearing the patch, etc. But I think your question is much more, how would somebody else look at this, or how can I go back and look at it? That is close, but that is a V2 of the patient information app.
great, thank you. From Valerie, are you interested in long QT patients that are non-symptomatic, not confirmed genetically, but identified clinically through ECG and other measures?
That's a really interesting population. It's something we grapple with in pediatric cardiology all the time, because if your QT is at some length and you have PVCs on your Holter, in the US, we have to restrict you from participation, or we have to recommend that you not exert yourself. It'd be really interesting to have this data in somebody who has a QT that's longer than normal. I'd look at how your QT responds to whatever stimuli are happening in your daily life, and I think it'd give us a ton of insight. So yes.
Yeah, great. What about using these devices to reduce travel burden for cardiac stress tests?
Oh, wow. It's almost like you read my mind. In December of 2025, Proleo cleared a new algorithm which basically gives us an estimated volume of oxygen usage, so what they call peak VO2 in your CPET. We can estimate it with a patch for a week, worn for a week on your activities of daily living. It is now FDA cleared in the medical sense, and I don't want to say this completely precludes CPET because they can get things that we absolutely cannot with this technology. But if you're just following peak VO2 from month to month, yeah, absolutely, that's what we built it for.
Great. From Richard, how much of the collected data do participants get to view? We went over that a little bit earlier, but consumer wearables present data to the wearer immediately, which makes them interesting to the wearer. I'm actually wearing a collection device as part of a study, and all it tells me is the time of the day. Boring.
Well, right now the cadence is every 30 days, mostly because if I gave it to you any more frequently, it would be super boring. There would be gaps where things were not measured yet. As we mentioned, the future state is to have it be something that you could log in much as you look at your app for your Aura or your Whoop, etc. So future state will be much more interesting to you. You may find the current state a long wait and a little boring, but we're working on it. Like I've got a Aura, this thing, that thing, so I'm with you.
Great. Susan just says, thanks, Susan. This is our last question. I wish my bicycle rides could be registered as activity. So cute.
They're not?
Yeah.
Oh.
Yeah, maybe they would. Yeah.
Yeah, you should talk to your wearable manufacturer.
Yeah. So before we move over, again, we'll send Nikki will talk about sending the stuff out after the fact. If you are interested, I mean, if you click on the link, you can fill some information out and talk with a nurse, I think, from Proleo, and to help you better guide you if you participate and if you can participate in any questions that you have. So if you're interested at all, click on the link, click on the QR code, and hopefully we can create better long-term outcomes for ourselves and our patients. Thank you, Greg. Thanks, everybody. Thanks, Nikki.
Thanks, everyone. Thanks, Greg. Thanks, Nikki. Thanks, everybody, for coming.
Thank you. I have just a few closing remarks here to get us wrapped up. So I do want you all to watch for this follow-up email that Greg's referring to. So as registrants, you will receive an email with a recording of tonight's webinar, and that email will also include this link to the OCORO Heart Study website and a link to register for our next webinar. I will also include the healthcare provider link in there as well, so I'll have separate links. And next slide. Our next webinar will be held Wednesday, June the 10th at 6 p.m. Eastern Time. We will be discussing AFTX-201, a next generation one-time genetic medicine for BAG3 dilated cardiomyopathy. Registration is open and information can be found on the DCM Foundation and GCAC websites. And remember, even if you cannot attend live, go ahead and register. You'll receive a copy of that recording via email. The next slide. Thank you to all of our sponsors whose logos you see on the screen. Their support allows us to present this important information. And thank you again to all of the patient partner groups for their ongoing support. Thank you, Justine, for your technical Zoom assistance behind the scenes. And thank you all for joining us this evening and for taking the time to learn more about the OCORO Heart Study and the future of heart research. We're especially grateful to Bethany and Hannah Keim, Walker Fromm, and Dr. Greg Kurio for sharing their insight, experiences, and dedication to advancing awareness and innovation in cardiovascular care. To everyone who attended, thank you for your curiosity, your questions, and your commitment to supporting progress in the inherited heart disease community. We hope this conversation leaves you feeling informed, encouraged, and empowered to continue learning and sharing these important resources. Have a wonderful evening, be well, and we'll see you again very soon.